Hello everyone, welcome to Neurosurgery 101. So I'm going to be presenting an introduction to neurosurgical anatomy and terminology to help prepare you for your upcoming coding training sessions. So everything that I cover today is going to be kind of brief in this presentation, but I just wanted to let you know there's more detail on some resources on Mayfield's website and YouTube channel. So I wanted to kind of go over in detail where those are so you can find them. So we have a robust library of educational pieces and also patient hope stories, and these are located at mayfieldclinic.com under the Health Topics tab. And then we also have a blog and a library of press releases that you can find underneath the News and Events tab. This is what our blog looks like. It's called the Mayfield Brain and Spinal Column. And then finally, Mayfield also has a YouTube channel with topics presented by our surgeons, as well as video patient hope stories. So all of these are really good resources for you guys to refer to if you need to go back and get more detail on anything that I've talked about today. Okay, so my presentation is going to be organized into three main topics. I'm going to go through brain, and then neurovascular, and then spine. And so for each one of these, I'm going to give an anatomy overview, and then I'm going to talk about some common conditions that we treat at Mayfield, and also talk about how they're treated. So first, I want to start with the brain. Okay, so working together, the brain and the spinal cord and the nerves are all responsible for collecting sensory information from our surroundings, and it controls our reaction to that information. So the brain is kind of like the control center for all of this, and the spinal cord and the nerves are like the communication system that relays information back and forth between the brain and the body. Okay, so we have 12 pairs of cranial nerves that branch from the brain, and we have 31 pairs of spinal nerves that branch from the spinal cord. All right, looking more into the brain. Brain has three main parts. The largest part of the brain is the cerebrum, which is kind of like the thinking part of the brain. It also interprets our senses, and it has everything like vision, your hearing, your speech, your reasoning, your motions, your learning and your memory. That all happens in your cerebrum. And then there's the cerebellum, which is responsible for coordinating movement, posture, and balance. And then the brainstem controls functions that are automatic. So these are the things that you don't have to think about, things that happen when you're sleeping, such as your breathing, your heart rate, your temperature, digestion, things like that. Okay, and then another thing you want to know is that the brainstem continues down the back as the spinal cord. And another thing to note for later when we're watching surgery is the surface of the brain is very folded and convoluted. Each fold is called a gyrus, and they're separated by these grooves or valleys called sulcuses. This is kind of an exploded view of that gyrus and a sulcus in between. And so surgeons can use these naturally occurring grooves to their advantage in surgery. And the way they do that is they can spread these grooves to access structures that are deep within the brain without having to cut or retract really hard the brain tissue, which would be damaging because the brain is so delicate. So since the brain and the spinal cord are very fragile, they have a lot of protective layers surrounding them, and I'm going to walk you through each one of them. So the innermost layer of protection is a fluid layer, and it's called cerebrospinal fluid. And it kind of surrounds the brain, and it acts like a watery cushion in case your head gets bumped and jostled. Now, CSF actually has its own circulation system within the brain. So it's created in the ventricles, and then it circulates around the brain in order to bathe and cushion it. Okay, the next layer is a very tough fibrous layer called the dura mater. And this is a tough watertight membrane, and it seals up the CSF so you don't get CSF leaks. And the dura is actually one of several protective coverings of the brain that are collectively called the meninges. And I want you to remember that word for later on when we talk about brain tumors. And of course, all of this is enclosed by the bony skull and the spine. Okay, so here's the skull. Skull's actually formed from 8 separate bones that fuse together along these lines. I'm hoping you can kind of see my little laser pointer. So these lines are called sutures. And surgeons can use these sutures as landmarks when they're doing surgery to know which part of the brain is located beneath. So when they're doing surgery, they use these sutures as landmarks. And when they're doing a surgery, the way they access the brain is through a cutting in the opening. They open up the skull with a cutting called a craniotomy, and this is actually a procedure in itself, cutting a window in the skull in order to see the brain. Okay, so now that I've given you a little bit of background on some of the basic anatomy of the brain, let's move into some detail about brain tumors and how we treat them. So for reasons that we don't quite understand, brain tumors are formed from cells that grow uncontrollably. And they're named according to the structure that they grow from. So meningioma grows from the meninges. So like we talked about earlier, these are the protective coverings of the brain. That's where the meningioma grows from. You can also have brain tumors that grow from neuromas, which are nerves. Nerves are called neuromas. And then you can have tumors that grow in the pituitary gland. That's called pituitary adenoma. So these types of tumors tend to be benign because they don't really invade the brain tissue itself. They're encapsulated and they're kind of firm, so that when they grow, they push the brain tissue aside rather than actually invade it. So the danger of the benign tumor is that as it grows and gets larger, it's going to squeeze and possibly compress vital structures. You're going to get symptoms depending on which structure is compressed. But one of the benefits of the benign tumors is that you can kind of see from this MRI that the borders are fairly clean because they are encapsulated. So they tend to be able to be removed fairly easy and usually completely without damaging the brain tissue. And then we'll contrast this with a malignant tumor, which looks much different. So malignant tumors actually grow from the brain tissue itself, and they're invasive. So they're very difficult to remove because their borders are irregular and they're not well defined, like you can see in this MRI, okay? And these tumors are usually known under the umbrella term of glioma. And they're called this because they grow from the glial cells of the brain. And I've listed 3 types of gliomas: the astrocytoma, oligodendroglioma, and glioblastoma. These are 3 types. And these tumors are graded on a scale of 1 to 4 based on their invasiveness, aggressiveness, and their tendency to recur. Okay, and finally, brain tumors can also be classified as primary or metastatic. So a primary brain tumor is one that originates in the brain. And a metastatic tumor is actually cancer from another part of the body that has spread up to the brain. And what I've shown here is skin cancer. So the top 3 cancers that metastasize to the brain are lung, breast, and skin cancer. So how do we treat brain tumors? So there are 3 main ways. You can do surgery, radiation, or chemotherapy. They can be used alone or in combination with one another. So surgery removes the bulk of the tumor at once, and if the tumor is benign, this may be the only treatment that you need. But if it's near critical structures or if it's malignant, it may be removed in part and then followed up with either radiation or chemotherapy to continue killing the rest of the residual tumor cells. Now, radiation, it damages the DNA of tumor cells, and this stops their cell growth, and that's how it kills the brain tumor. Now, radiation can be delivered in several ways. It can be delivered to the tumor from outside the body using machines such as the Linac machine or the Gamma knife, which I've pictured here. And radiation can be given in low doses over multiple visits, which is called radiotherapy, or in high doses over like 1 to 5 visits, and this is called radiosurgery. Okay, radiation can also be delivered from within the body. And the way they do this is they use radiation seeds, such as the gametile, and this can be placed directly into the tumor cavity during surgery to immediately begin targeting the residual tumor, and it will delay the recurrence of some tumors like GBMs. And this method of radiation is called brachytherapy. Okay, and finally there's chemotherapy. It can be delivered in several ways as well. It can take it by mouth, it can be delivered by IV, or it can also be placed inside the tumor cavity as well in the form of wafers. Okay, so now I'd like to focus for a little while on surgery. So I'm going to walk you through the steps of an actual brain tumor surgery. Okay, so an important part of surgery is actually planning the access to the tumor beforehand. And surgeries use a technology called stereotactic navigation, which helps them to actually see inside the patient's head while they're planning. So what happens is the patient gets an MRI before their surgery, and that MRI data is loaded into this computer system, and then a 3D image is generated of the patient's head from the MRI data. And then as the patient's lying on the bed, they register the patient, and this means to kind of match up the patient's head position with the MRI image that they're seeing on the screen. And they use this with the help of these little devices that they place on the head, which are called fiducials. So what the surgeon does is when he's holding his pointer, this is an infrared pointer, and the camera in the OR room sees that pointer, and it picks up its location and it sends it to the computer so that he can kind of see on screen where his pointer is as he moves it over the head. And in that way, he can see the pointer in relation to the tumor that's inside the patient's head, and this helps him to plan his skin incision and craniotomy to be as small as possible and still access the tumor. And so here's kind of what that looks like in surgery. So you can see he's drawing on her head with a marker as he's holding the infrared pointer. And then he can kind of see where that pointer is on the MRI data that's on the computer screen. And this is what it looks like when he's done. So he's traced the outline of the tumor here, and then he's planned his skin incision over the top. Okay, so now once he's in surgery, they can do this again after they've done the skin incision and they've retracted the skin, and now you're kind of looking down on the bone, the skull bone. So he can use his stereotactic navigation again to draw that tumor again on the bone, and that way they can cut the bone window around the tumor. So I want to talk a little bit about the craniotomy, what that looks like. So when they do a craniotomy, they do it in two parts. The first part is this little hole that's called a burr hole. And that's kind of like a pilot hole that they can insert their drill in order to cut the larger cut around the craniotomy, okay? And so then they can remove that as a bone, they can remove that bone, and then they can see further down to see the dura overlying the top of the brain. So the next step is to open the dura, and then they can locate and remove the tumor inside the brain. And so I wanted to show you a video of this part because this is going to show him locating the tumor and then taking it out. Okay, so right now he's actually cutting, and this is not the brain itself. This is another protective layer of the brain that is underneath the dura. So he's kind of got the dura flapped away here, and he's making an incision in the arachnoid layer. And now this is actually separating the brain tissue. And thinking back from earlier in the presentation, he's using the natural groove of a sulcus. So you notice he's not cutting, he's just separating. And now he's located the tumor, and you can kind of tell that it's a different texture than the normal brain tissue. And you can kind of feel that difference in his instrument. It's firmer and it's got a rougher texture to it. Now he's gently separating the tissue from the tumor. And when he's sure he's got it separated, he takes it out with his forceps. And after he does that, he's going to examine the tumor cavity, which is the place where the tumor was before. He's going to make sure that there's no bleeding, no residual tumor cells left in the cavity. And another way he can use stereotactic navigation is at this point, he can use that to check the perimeters of the tumor cavity to make sure there's no tumor left. Okay, and then finally, once they've done all that, they close it up layer by layer. So he closes up the dura layer, and then he replaces the bone flap, and he secures it with these titanium plates. And then they close up the skin with either staples or tissue glue. Okay, so that wraps up my session on the brain. Are there any questions at this point about what I've covered so far?
So with the stereotactic navigation that you just discussed, how is it distinguishing the tumor from the regular brain cell? Is it color, is it material, or is it some other methodology?
Okay, so the question is, how does he tell the tumor from the regular brain tissue? How does the stereotactic navigation know that? So I think that's done during the planning phase. So the surgeon actually can draw and plan. So when he's planning his access to the tumor, he can tell the difference visually on the MRI, and he draws that. And so therefore, when he's in the surgery, you can kind of see, I'm going to go back to my picture. So he's drawn these lines as reference points. And so he's kind of using those to tell. So it's really not the navigation device itself that's telling the difference. It's his planning that he's drawn over it. Okay.
What happens to the void in the cavity? Is it placed with the implant, or does it just fill over time?
Yeah, so the question is, what happens to the cavity after the tumor's been removed? Does it stay open, or what happens? And so for the most part, the brain tissue is very soft, and so it just fills in. So it just goes back to normal. And it almost, you can kind of see that in the picture. It's very pliable. So it goes back to the way it was. And they just want to make sure there's no CSF leaks or anything that's going to fill it in, and they can take care of that. Okay. Ready to move on? All right, so let's move on into neurovascular. So I want to talk about the blood supply of the brain. So it receives blood from actually two systems of arteries. One is the carotid artery system. It's shown here in green, and it actually supplies the front part of the brain, and it's called the anterior circulation. And then the vertebral arteries, they're shown in red, and they supply the back part of the brain. And this is known as the posterior circulation. And in the middle, there's this network of vessels that kind of connect the two. And so that way, one system can compensate for the other if there's a blockage. So that's the importance of there being two systems of the brain vascular supply. So before we move into stroke, I wanted to include this slide just so that you have it as a labeled reference of all the main blood vessels of the brain, all the main arteries. So a stroke is a sudden loss of blood flow to the brain tissue, and it causes brain death, or brain tissue death, sorry. So this can happen in several ways. So one way you can have a stroke is by arteries rupturing and bleeding, and this causes a pool of blood to accumulate in the brain. So if this happens inside the brain itself, inside the brain tissue, it's called an intracerebral hemorrhage, or an ICH. And this bleeding is most often caused by high blood pressure that ruptures these tiny blood vessels, and a hematoma forms over time. Now, if a large artery ruptures and releases blood outside the brain, between the brain and the skull, like this one, this is called a subarachnoid hemorrhage, or an SAH. Okay, and the pressure, it's actually the pressure and the toxic blood products on the brain. That's what causes that sudden severe pain and vomiting that's associated when people have hemorrhages and they say, I'm having the worst headache of my life. So that's actually what causes that great pain. Now, if a vessel becomes blocked, this can also cause a stroke, and this is much more common. So inside an artery, a plaque can build up on the sides of the wall, and it's kind of rough and sticky. So what happens is it snags blood cells as they flow past, and this can build up over time to form a clot. It's called a thrombus. And this can completely block the blood flow and cause a stroke. Clots can also come from the heart. So if they break loose and they flow downstream, that's called an embolus. So if you're having an actively occurring stroke, you can be given a drug called TPA, and it's injected. And this may dissolve the clot if it's small enough, and if the TPA is given within the 3 to 4.5 hour time frame in order for it to work. But if it's a large clot, it may not dissolve, so then we can retrieve it with a device, and this is called a thrombectomy. It's an endovascular procedure, and endovascular means it's a procedure that's performed completely within the inside of the vessel. So what they do is they feed a catheter up into the artery containing the clot, and then a wire mesh stent is fed through the catheter, and it's expanded within the clot in order to kind of snare it. And then the stent pulls the clot back into the catheter, and this is with the aid of the catheter suctioning to prevent the clot from dislodging and flowing downstream. And once it's inside the catheter, then the clot and the stent and the catheter are all removed from the body. So how did they get up there to the brain in order to do that? So what I'm going to show you now, this is kind of the basis for endovascular procedures in general. So what they do is they insert a microcatheter into the large femoral artery in the groin, and they guide that catheter up through the body, all the way up through the heart, through the whole circulation, until it reaches its destination, and then they perform the appropriate procedure to correct the problem. There's different types of endovascular procedures, and that includes the thrombectomy, aneurysm coiling, carotid angioplasty, and also stenting for flow diversion. Now this is performed in an angiography room, and here's a photo showing that. So you can see the patient, and they're actually awake during this procedure, and there's a fluoroscope that takes X-ray images during the surgery that the surgeon can watch live as he guides the catheter up to the arteries in the brain. So this is the screen that he's watching, and you can kind of see the catheter here as it's en route past the heart. So now let's talk about aneurysms. These are actually the most common vascular condition we treat at Mayfield. So an aneurysm is a balloon-like bulge from a weak spot in an artery, and it usually is formed where the artery branches or bifurcates. So it can eventually enlarge and burst, but many aneurysms remain unruptured. So if one is discovered, a decision may be made to treat the aneurysm based on the risk of it rupturing. So there's several ways to treat an aneurysm. One is to put a clip on the outside of the neck of the artery of the aneurysm here, and that shuts off the blood flow going into the aneurysm. And this is a surgical procedure that's performed through a craniotomy like we saw earlier, and this is what a clip looks like. Now in endovascular procedures, they shut off the aneurysm from within the artery itself. So some examples are coiling, which fills the aneurysm with tiny hair-thin platinum wires to prevent the blood from entering the aneurysm. Flow diversion is a mesh tube that's placed into the main artery, the parent artery, and this diverts blood flow away from the aneurysm. And then finally, this is a new device, and it's called a woven endobridge, or a web. And it's like a mesh ball that's placed into the aneurysm. And it's kind of the similar concept to coiling. So this is a short video or animation showing just the coils being deployed inside the aneurysm. And these angiograms, these show before and after. So before, you can see the blood in the aneurysm before it's packed. And then after it's packed, the contrast dye that they used earlier is no longer filling the aneurysm, so you can kind of see the outline of the coils faintly. So the final vascular issue that I'm going to look at is carotid artery disease. It's also called carotid stenosis. So this is when plaque builds up inside the carotid artery in your neck, where it branches into the external and internal branches. So it can form a large mass that's large enough that it can narrow the artery's lumen enough to decrease the blow to the blood flow to the brain and increase the risk of blood clots forming. So it can be detected by a Doppler ultrasound in the neck, and that's kind of what this looks like. You can see this black area here is the plaque. You can tell how that's narrowing the blood flow as it goes through the artery. So here's some way that we can treat that. It can be treated by an aneurysm, endovascular procedure called carotid angioplasty and stenting. So first they insert a balloon into the artery and they inflate it, and that compresses the plaque up against the wall of the artery. And then they can place a stent in to permanently hold the artery open. Okay, and finally, a carotid endarterectomy. This is a surgical procedure. And in this procedure, the artery is actually opened by an incision, and the plaque is peeled off of the artery wall and removed completely. Okay, so this kind of ends the vascular part of my presentation. Do you have any questions before I go on? Okay.
So why do they start in the groin versus an area that's closer to the brain?
That's a great question. So the reason is the femoral artery in the groin. Okay, let me repeat the question. So the question that was asked is, why do they start way down in the femoral artery, which is in the groin, instead of closer up to the head? So the answer is the femoral artery is larger, and it's tougher for that reason. It has thicker walls, because an endovascular procedure is kind of tough. He's having to drive this catheter up into their body, and that's it's kind of traumatic to the artery. So they don't want to start it in a tiny artery closer to the head. Okay.
So we saw that you could treat aneurysms by an open cranie with clipping, or endovascularly with coils or stent diverters. Do you know how the surgeon decides which approach to use for a particular patient?
Okay, so the question is, how do they choose between an open surgery, craniotomy, to treat an aneurysm versus a endovascular procedure? So first I wanted to tell you there's a really good video on our YouTube that's done by Dr. Ringer, and he addresses that exact issue. So the things that they weigh to determine whether we do surgery or endovascular. And so I can give you kind of a brief answer here. So a lot of it has to do with, a surgery is a permanent procedure. And so if they place the clip, you probably won't have any problems after that. It's usually no recurrence of any issues. But the other thing is it's surgery. So, you have to determine if you're a good candidate for surgery. If you're not as good of a candidate for surgery, then endovascular would be less, it would be a safer procedure. But you usually have to check up on endovascular type procedures because they're not always as permanent as the surgical clipping is. So those are kind of the factors that they have to decide. So maybe age or health. If you're younger, you may recover from a craniotomy surgery better than someone who's older. There's other factors as well. Does that help for now? Yeah. Okay. Okay, cool. Anything else? All right, so let's move on to spine. So this is a view of our spine from the side. The spine is formed from 33 bones called vertebra, and it's divided into 5 regions. And the regions are kind of determined by their function. So up in the top, we have 7 cervical vertebrae in the neck, and those are very small for maximum flexibility of your neck. And then there's 12 thoracic vertebrae, and that's where your ribs are attached. Then there's 5 lumbar vertebrae, and these have very large bodies because you have a lot of weight bearing in that area. And then there's the sacrum, which is 5 fused vertebrae, and then you have the tailbone or the coccyx at the end. And then the SI joint, which you may have heard of, the sacroiliac joint, that is this joint that connects the sacrum to the hip bone, which is also called the ilium. So each vertebra in your spine is separated and cushioned by a disc that keeps the 2 vertebrae from rubbing together or pinching the nerves. And discs have two layers. They have an outer layer, which is called the annulus, and it's kind of tough and fibrous. And this actually attaches to the vertebral bodies to hold them together. And then inside, there's a softer inner layer called the nucleus. And this is mostly fluid. And that's actually the part that squeezes out when you have a herniated disc, which we'll see some examples of that in a minute. So when you stack all the vertebrae on top of each other to form the spine, this creates some natural occurring canals for structures to travel through. One is the spinal canal, runs from the top of the spine to the bottom. And then there's the intervertebral foramen, and these are holes that run down the side of the spine between each vertebra. You can see that this is an axial view of the spine from above. So here's the vertebral canal, and here's the intervertebral canal, or the intervertebral foramen. So the spinal cord is what runs through the spinal canal, and it's protected by the lamina of the vertebra. And I want you to remember that word for later on when we talk about laminectomy surgery. And then there's nerve roots that branch from the cord at each vertebral level, and these are actually located in the intervertebral foramen. So you can see them here, and on the side view is here. So in a healthy spine, there's a lot of room in the cord and the nerve area for these to move around freely with no pain. But changes can occur with age or injury that narrow these spaces. And for instance, your disc can dry out, your bone can become overgrown and arthritic, ligaments inside the spinal canal can enlarge. Okay, and all these things working together can compress the nerve roots or the spinal cord in these spaces. And this is what causes the pain and other symptoms of the conditions that we treat here at Mayfield. So one more thing, the back is, this is the back view of the spine, and I've colored in the middle vertebra so you can kind of distinguish it from the one above and below. So the vertebrae interlock with each other to form a set of joints at each vertebral level, and these joints are called the facet joints. And this is where facet joint injections are made, and we're going to look at those later on, so I want you to remember that's where the facet joints are. So the facet joints in the back of the spine and the discs in the front of the spine is what allow the spine to bend and flex and have its great strength. And at each vertebral level, the disc in the front and the paired facet in the back is what surgeons called a motion segment. So this is a cross section of the spine so that you can kind of see the spinal cord traveling down the spinal canal. And you can see the nerves. There's a nerve that branches at each vertebral level. The stripes on this diagram, this shows the pathway of the nerve through the body. And when a spinal nerve gets compressed at the root where it branches from the spinal cord, you can have pain or other symptoms anywhere along the pathway of that nerve. And so the doctors can kind of locate a person's symptoms by using this pain as a guide. Where he has pain, they can tell what vertebral level that the pain is being actually originated from. For example, someone may have pain down their arms or in their hands. This may be actually being caused by a problem that they're having up in the neck with the nerve roots being impinged. So if a nerve root gets compressed, pain may travel or radiate along the pathway of the nerve, and this type of pain is called radiculopathy. So radiculopathy can be sharp and shooting, it can be numbness, tingling, burning, and one really common example of that is sciatica. That's a radiculopathy issue. And the other type is myelopathy, and this is actually caused not by compression of the nerve roots, but compression of the spinal cord if the canal becomes narrowed. And it causes a variety of symptoms, but basically it affects motor skills. So you can have weakness, clumsiness, coordination type problems. They may have trouble walking, tying shoes, holding a cup of coffee, those kinds of things. That's myelopathy. So on the left, I've kind of listed kind of a complete list of the spinal disorders that Mayfield treats, and these are the four main ones that I'm going to cover. So this is a side view of a normal lumbar vertebra. So in a normal view, we can notice that the disc is normal height, and there's also nice space in that foramen. So if you have degenerative disc disease, those discs are going to become thinned and they can't maintain that space between the vertebra. So the nerve is going to become compressed in the foramen. You can also have bone spurs form, and this can further irritate the nerves. And then there's spondylolisthesis. This is when one vertebra slips out of alignment with the one beneath it. And when that happens, it can kink the spinal cord and the canal and the nerves. Okay, here's an axial view of a normal vertebra. So what we're looking at here is nice space in the intervertebral foramen and nice space in the canal. So if you have a herniated disc, the nucleus ruptures out of a tear in the annulus. And that nucleus is actually an irritant to the nerves. So that's kind of what causes the pain of a herniated disc. Now they usually herniate more laterally into the foramen, but they can also herniate more centrally, okay, and compress the spine. And there's an emergency condition called cauda-equina syndrome, and this is when you have a very large herniated disc in the lumbar area, and it can be large enough to press on the nerve roots at the tip of the spinal cord. And that area controls your bowel and your bladder function. So if you're having issues with that, or saddle numbness is another thing that can cause, and it just also causes excruciating pain. So those kind of symptoms need a trip to the emergency room. This is emergency and it needs to be taken out, the herniated disc, as soon as possible to avoid permanent damage to the nerves. So in spinal stenosis, it's what we see here, the spinal canal or the intervertebral foramen, they become overgrown and narrowed over time, and it compresses the nerve. If the spinal canal is narrowed, this is called central stenosis. And if the foramen is narrowed, that's called foraminal stenosis. Okay, so the foraminal affects the nerve roots, central affects the canal, connects the cord. So about 80% of our patients recover from conservative treatment without needing surgery. So I wanted to talk some about non-surgical treatments. So here's a list of the common conservative treatments. The goal with conservative treatment is to keep pain under control so that the patient can move as needed to do their daily activities. They can take physical therapy, condition and strengthen their spine, and get better. So what I'd like to focus on is injections. And this is a way to deliver medication directly to the source of the patient's pain. So first is epidural steroid injections, or ESIs. These help alleviate nerve root pain caused by stenosis or herniated disc or degenerative disc disease. Okay, so the medicine is going to be placed into that foramen, into the epidural space, which is between the nerve and the bone. The effects of ESI vary, but if successful, they can be repeated as needed. And then there's joint injections. So these are actually delivered right into the inflamed joint. So the needle is inserted into the joint capsule, and then it delivers the same type of medication as used in an ESI. So these are a list of the common ones that we do at Mayfield. And the thing about joint injections, if you don't have any relief after 2 of them, that means the pain is probably not coming from your joint. So they need to do further testing to determine where exactly the pain is coming from. But if the injections are successful, but you need to keep having them frequently because the pain keeps coming back, then you may benefit from a more permanent procedure, which is called a radiofrequency ablation. Okay, but because that's more permanent to the nerve, they're going to do what's called a nerve block test, just to make sure that it's the nerve that's the problem of the pain, and so it is a joint problem. So what they do is they inject an anesthetic only along the nerve that supplies the joint. It's called the medial branch nerve. It's not injected into the joint itself. And also they're just using an anesthetic, not the steroid. So if you have significant pain relief after you've had these, then that confirms that the pain is coming from the nerve, and then they can recommend an ablation. So in an ablation, this actually deadens that nerve, the medial branch nerve, for an extended period of time, sometimes up to 6 to 12 months. What they do is they insert an electrode into your skin, and it delivers a small burn right to the precise area of that nerve that's causing the pain. This is called a lesion. So the nerve actually may grow through the lesion again, so your pain may return, but if it does, you can have the procedure repeated again if necessary. Okay, now move on into surgery. So in general, spine surgery can be done as an open or a minimally invasive procedure. So the difference is how the spine is accessed. So in an open procedure, like I have here, the incision is several inches long and the muscles are kind of cut from the bone, detached, and the opening is held open with retractors, and this is to allow a large field of view so they can look down on the spine and operate. But this is more traumatic to the tissues, okay, since there's cutting involved, and so there may be a longer hospital stay, more pain, more scarring, longer time to recuperate. Now, in a minimally invasive procedure, the skin incision is much smaller, and also the muscles are dilated rather than be cut, so that's much more gentle to the tissues. And they perform the procedure through this tube, and there's a light source that they put in the tube so they can see inside. So many procedures can be done either open or minimally invasive, and so they're going to make the choice based on the individual patient, which one will be better. So the main types of surgeries that can be performed minimally invasive are spinal fusion, deformity corrections, and herniated discs. So I just wanted to show you this animation of the beginning of a minimally invasive procedure. So this patient's lying on their stomach. The incision is in the lower back area. So here what they're doing is they're inserting tubes of increasing diameter, and that's what dilates the muscle instead of cutting it. And then once they get the right size, then they insert the surgical port, which was what you just saw there, and secure it in place. And then finally, they insert a light source so they can see inside that small tube. Okay, and from that point, they perform whatever procedure is needed to correct the problem. So now I'm going to talk about a couple of common surgical procedures that we perform at Mayfield. The first is a spinal decompression. Okay, so basically a decompression is performed to remove parts of the vertebra in order to relieve the compression that's on spinal cords and nerves, and this is commonly performed for stenosis. So they remove either all or part of the roof over the spinal canal called the lamina, like we saw earlier. This is called a laminectomy. And then they drill off the enlarged part of the facet bone, the facet joint, and that's called a foraminotomy. Okay, and that decompresses the nerve. So here's the nerve, here's the spinal cord in the space after they've removed the bones. Now, lumbar discectomy is performed to remove just the ruptured portion of a herniated disc in the lumbar spine area. So this is performed from the back. And again, they do a laminotomy to expose just the herniated portion of the disc. And this is kind of what a laminotomy looks like from the back. It's just a small hole in the back of the vertebra. And then they remove the portion of the disc that's ruptured. They don't remove the entire disc. And then the other thing that they do is they kind of go in and clean out any kind of bony overgrowth in the canal and in the foramen that's needed. Okay, and finally I want to talk about fusion. So this fusions are formed for patients with spinal instability, meaning there's a painful abnormal movement between two or more vertebrae. So a fusion kind of joins those vertebrae together and aligns the spine, and it stops that painful motion between the bones. And there's two components that you need in order to make a fusion. The first is a device called a fusion cage, and it's placed between the vertebra to restore the disc height. And the reason it's called a cage, it has an opening inside of it that they place material in it, and the material is to create bone growth between the vertebrae, and that's what makes the fusion. So that material can either be shavings taken from your spine when they're doing the surgery, or you can have it from a bone bank, or you can have a synthetic material. It's an autograft if it's your own bone. It's an allograft if it's cadaver bone. And then there's the hardware, such as the screws and the plates and the rods. And this is what holds the bone in place while the fusion takes place. And the fusion is actually what happens in about 3 to 6 months after the surgery. New bone actually forms between the two vertebrae, and they literally become a solid piece of bone. So here's some x-rays examples of before and after fusions for these two conditions. So for a degenerative disc disease, you can see how the disc space is narrowed. And then fusion, they've opened up the space and they've secured it with the screws and the rods. And here's spondylolisthesis, sorry. You can see L4 is over top of L5 out of alignment. And then they can pull that back into place with the fusion. And here's the cage that's inside there. Okay, so I wanted to give you this slide just for your reference. So fusions can be performed from different angles to the body, and that's where you get all the different names of the different types of fusions, like L-LIF and P-LIF and T-LIF, all those acronyms. That basically just tells you which direction they're coming from to the spine. So for example, the A-LIF is performed anteriorly or from the front, meaning the surgeon's going to go through the stomach. And a lateral fusion's from the side. The incision is going to be near your waist, above the hip. And then they can also perform posterior fusions from the back. You're going to lay on your stomach, and he's going to approach your spine from the back. And then in between, they kind of have the O-lifts and the T-lifts, and then the axial lift. So now that we've kind of learned about fusions and discectomies separately, we're going to put them together, and that's what an ACDF is, or an anterior cervical discectomy and fusion. So they're going to remove a disc, that's the discectomy part, and then they're going to perform a fusion, so that's the fusion part. And this surgery is done in the neck for a herniated cervical disc, and the incision is made about right there, wherever the level of the herniation is. Okay, now this, I wanted to show you the surgery procedure for this over several brief videos, and this is kind of the format of the slide that I'm going to use. So I'm going to orient you to the surgery video. So this is actually an open procedure. You can tell because they're using retractors. And then in the surgical field, the disc, you're going to see it when they incise it, but the disc is right here in the middle, and then you'll be able to see vertebra above and below it. Now, some of the area that he's going to be operating in is out of his surgical field, and so we're going to see that, and we're going to see how he deals with that in just a minute. Okay, so here he is incising the disc with what's called a bovie, and this is actually it's a cautery, so he's burning as he's cutting. And that's the disc that you can see, and he's reaching in, he's grabbing it with an instrument called a rongeur. And if you look closely, you can kind of tell the difference in the texture of the annulus and the nucleus. Annulus was kind of tough. Now he's going to go in and pull out the nucleus, which is a little fluffier. So he removes about 2/3 of the disc, and then he also removes the posterior longitudinal ligament that runs behind the vertebra. So the next step is that he's going to widen that disc space. And he does that by actually drilling off the edges of the bone. He's going to clean it up so he has a nice wide opening. And it not only widens the disc space, but it also exposes the blood-rich bone marrow. And the reason he does that is that the graft needs contact, or the material that's packed in the cage needs contact with that natural occurring blood material in order to grow new bone. So now you can see he's widened the space. And next, now this part of the surgery, he's going in and he's cleaning out the foramen, which is off to the side. So this is kind of out of his surgical field. So as you can see, he's reaching into the foramen with a biting instrument. I think that's the rongeur again. And then this instrument is called a feeler, and he uses that to kind of feel around in the foramen to see that he's gotten all of the bone spurs off. Okay, the next part is to insert the fusion cage. And before this, he's kind of sized it so it'll be the right size. So they go through several series of getting the right size before they put the final one in there. And now he's tapping it into place. So that's what the fusion cage looks like inside. Okay, and this is the final step of the procedure. So this is when they put the plate on the front of the vertebra. And all this really does is just hold the bones in place while the fusion of the bone is occurring. By the way, smoking is the #1 cause of failed fusions. So that's why we have patients stop smoking before they have their fusion procedure. It's because nicotine is a bone growth retardant. So that's why it's really important for patients to stop smoking before they have a fusion. And here's an X-ray after. You can see the bone graft. And here's the plate in the front. So this is from the side view of the neck, and this is the front view. So there's that plate there. Okay, the final thing that I wanted to mention is the downside of a spinal fusion is that it actually, since it forms a solid piece of bone, you have some loss of mobility in your neck. So artificial disc replacement, it's also called arthroplasty, is an alternative to fusion, and that is designed to preserve that motion in your neck. And so the surgical steps are identical to the ACDF, but instead of placing the fusion cage, they place a movable implant. And you can see after how they're able to bend and flex their neck. There's lots of different types of these, but I included this X-ray. I think it's a neat example of this. This patient's actually had an artificial disc and an ACDF, so you can kind of see what the difference in the two look like on the X-ray. And that's the end of my presentation. Thank you.